Hello, my name's Alexander. I'm a provisional anaesthetic registrar working in Queensland. In this session I would like to introduce to you one of my favourite nerve blocks, the ultrasound guided axillary nerve block. In this video I'll be discussing the indications for performing an axillary nerve block, including some advantages it has over the other brachial plexus blocks. I will also briefly review the anatomy relevant to performing this procedure. I would briefly touch on the elements of consent you need to discuss with the patient. I'll then demonstrate the technique, and finally touch on the assessment and follow-up after performing this block. So, when is an axillary nerve block useful? It covers the regions below the elbow up to the level of the mid-arm, making it particularly good for orthopedic surgery, such as surgery on the hand or carpal tunnel releases, and also very useful for vascular surgery, fistula formation in particular. There are two main advantages for performing these surgeries using a nerve block. Firstly, it may avoid the need for general anesthesia and all of its potential adverse effects, which is particularly desirable for elderly patients or patients with renal failure with all their associated comorbidities. Secondly, these nerve blocks can last up to 16 to 24 hours and provide good analgesia for this period. From a procedural point of view, this nerve block is a lot safer than some of the other brachial plexus nerve blocks, such as the interscalene or the supraclavicular nerve blocks, where there is a significant risk of involving the phrenic nerve or causing a pneumothorax. In addition, all of the structures lie in a very superficial position. Inadvertent vascular puncture can therefore be easily compressed, and the nerves themselves are very easy to access. I therefore feel that this block is ideally suited to a trainee who is in the early stages of learning ultrasound blocks. The disadvantages of this block is that it doesn't cover the structures involving the upper arm or shoulder, as the axillary nerve isn't blocked. Therefore, this block cannot be used for surgeries involving these areas. In addition, it often doesn't cover the area where a tourniquet is applied, which is often used in orthopedic surgery, and this must be taken into consideration if the patient is going to be kept awake during the surgery. The third disadvantage is that the anatomy can be quite variable in this region, and the nerves can be quite difficult to locate. However, the use of the ultrasound can overcome this. Now let's move on and review the anatomy. This is a cross-section of the arm just distal to the axilla. There are two muscles marked, the biceps and the coracobrachialis. These are useful landmarks when using the ultrasound. Here is a closer view of the anatomy that was within the red box. The axillary artery is a useful landmark as it can be easily seen by the ultrasound, and all the important nerves lie in close proximity to it. The axillary sheath, shown here, is not usually visible under the ultrasound, but is important as it will restrict the spread of local anesthetic. This is very relevant for the one nerve that lies outside of this sheath, the musculocutaneous nerve, shown here. It is important to target this nerve in order for the block to be effective. The other three nerves that lie within the sheath are shown here: the median nerve, which lies anterior-medially, the ulnar nerve, which lies posterior-medially, and the radial nerve, which lies posterior-lateral to the axillary artery. Remember, this is just a stylized version, and the anatomy can be a little bit variable to this. The other blue structures shown are the veins. Now, how does this look using ultrasound? The following is a typical image from a patient's axillary region. The region marked red is the artery, blue is one of the axillary veins, and purple are the two muscles, coracobrachialis and biceps. I will now mark out the nerves. The musculocutaneous nerve lies between the biceps and the coracobrachialis muscle and is usually quite flat. The remaining nerves here, the median, the ulnar and the radial nerves, are located where they are expected to be, but you notice that they are existing in a number of branches rather than just one single nerve. Be aware that anatomical variations such as this are quite common in the axillary region. Before performing any block on a patient, you must obtain informed consent. General elements include the risk of hematoma, infections, and allergies to the cleaning solution and local anaesthetic agents, but more specifically to nerve blocks, you should mention the risk of local anaesthetic toxicity, which is thankfully rare, the risk of nerve injuries, particularly to the upper limb, which can be permanent in some cases, but again rare. But very importantly, for a block such as this, you must inform the patient that their arm will be numb and paralysed for up to 24 hours, and they must take great care not to injure or burn this limb during this time, as they will be unable to detect that damage is occurring. Now, the equipment you will need. You will need an ultrasound machine with a linear transducer that is at least 30 millimeters long. You will need a sterile tray with 2 syringes, a 5 and a 20 or 30 ml syringe. You will need needles, a 23 or 25 gauge to anaesthetise the skin, and then a needle to perform the block. I usually like to use a 19 gauge Quincke needle, which is a short bevel needle. But you can also use one of the many available echogenic short bevel needles. It is important that you do use a short bevel needle because this reduces the risk of causing a nerve injury. A short length of extension tubing makes it easier to manipulate the needle. You would also need to have your local anaesthetic solutions ready. There are a wide variety you can use here, but 0.5% ropivacaine or stronger is advisable. For a faster onset block, you can use a mixture of 1% ropivacaine and 2% lignocaine mixed 1:1. You will also need some sterile ultrasound conductive gel, sterile gloves, and some cleaning solution. A sterile gown is not usually required. Let's do the block. As is the case when injecting a large volume of local anaesthetic, it is mandatory to have intravenous access, ECG, and oxygen saturation monitoring applied before starting. This is the setup of the room as I like to have it when doing a block on the left side. The ultrasound machine sits at the foot of the bed and the tray sits to my right near the patient's head. This is ergonomically the best position. As shown here, where you can see the eyes, the hands and the machine are all in alignment. Ideally, the block should be performed in an awake patient. Some light sedation such as 1 mg of midazolam or 25 micrograms of fentanyl is appropriate, but as long as the patient is communicative. They will be able to report severe pain if local anaesthetic is incorrectly injected into a nerve rather than around a nerve. Clean the area with a sterilising solution. I like to use chlorhexidine in alcohol, but betadine is also acceptable. This picture also demonstrates the ideal position for this block, with the patient's head turned away, the arm abducted and externally rotated. Next, prepare your local anaesthetic solutions. Draw up lignocaine in the 5 ml syringe to anaesthetise the skin, and then draw up 25 to 30 ml of ropivacaine, and then prime the extension tube and needle. Make sure there's no air bubbles remaining because these severely degrade the ultrasound image if injected. Anaesthetise a small patch of skin with the lignocaine solution. This is important because a short bevel needle can be quite painful when passing through the skin. It doesn't matter if you're left or right-handed. I like to hold the probe with my non-dominant hand and hold the needle with my dominant hand. Place the probe on the medial aspect of the arm, 1 to 2 centimeters distal from the axilla, parallel to the chest wall. Locate the pulsating axillary artery and try to identify the surrounding structures. Insert your needle 1 centimeter cephalad to the probe and aim directly under the probe and watch the screen for your progress. You must keep the needle tip in view at all times. If you can't see the tip, Tilt your probe slightly to get it back in view before advancing the needle further. When you think you're there, inject 1 or 2 mL of local anaesthetic. It should be easy to inject, and watch the screen carefully to see a expanding space. If you don't, you may be injecting into a vein. If it is very difficult to inject, you may be injecting into a nerve which could damage it, so stop. Reposition the needle before injecting again. In the image as shown, the local anaesthetic has been injected under the nerve, and the nerve now appears more brightly as a white stripe. Redirect the needle above the nerve and inject more local anaesthetic. Now you can see the local anaesthetic completely surrounding the now very bright musculocutaneous nerve. We can now move on to the remaining nerves. Now redirect the needle towards the median nerve. Again, aim just above or below it but not directly at it, and also avoid puncturing the axillary artery. Once you have reached your target position, inject a few mils of local and observe the response. As you can see here, it is spreading nicely along the medial anterior border of the axillary artery. Remember to keep aspirating before you inject, as there are many vessels here and you want to avoid an intravascular injection. Now repeat the procedure for the ulnar nerve. Here you can see the locals spreading posterior medially around the artery and the nerve. You should be aiming to inject about 4 to 5 mils around every nerve. And here the needle is placed just adjacent to the radial nerve, and you can see the locals spreading posterolaterally around the artery and the nerve. Now that you are finished, remove the needle and wipe off any excess ultrasound gel. Return the patient's arm to the side for them, because already they might have lost some proprioception and fine motor control. Finally, we have to assess whether the block has worked. You need to allow at least 10 to 15 minutes for this to occur. Test the operative site with ice just like you would an epidural before the surgeon starts operating. And finally, remember to thoroughly document the procedure. It is also good practice to go and see the patient or give them a phone call the next day to make sure the nerve block has completely worn off. And it's a good way to assess to see if they were satisfied with the experience. Thank you for watching. I hope this video gives you the grounding you need to perform this very useful block.